Now, let's move on to the next section, which focuses on the foot and ankle. Here you can see the basic anatomy of the foot and ankle. The main bones involved are the tibia and fibula, which are the two long bones of the lower leg, and the talus and calcaneus, which are the primary bones of the ankle and heel. The images show both a side and a back view, highlighting how these bones articulate to form the ankle joint and support the foot. This diagram provides a more detailed look at the bones of the foot and ankle. In addition to the tibia, fibula, talus, and calcaneus, you can see the tarsal bones, metatarsals, and phalanges. The subtalar joint, which is located between the talus and calcaneus, is also labeled. This joint is important for movements such as inversion and eversion of the foot. Now, let's look at the ligaments and tendons that stabilize the ankle. The Achilles tendon attaches the calf muscles to the heel bone. Several important ligaments, including the posterior and anterior talofibular ligaments, the calcaneofibular ligament, and the posterior inferior tibiofibular ligament, help maintain the stability of the ankle joint and prevent excessive movement that could lead to injury. Moving on to the muscles of the ankle, this slide shows both the superficial and deep muscles of the lower leg that control ankle movement. The gastrocnemius and soleus muscles, which form the calf, are responsible for plantar flexion. The tibialis anterior, extensor digitorum, and extensor hallucis longus are located on the front of the leg and are involved in dorsiflexion and extension of the toes. The deep muscles, such as the tibialis posterior and flexor muscles, play a role in stabilizing the ankle and supporting the arch of the foot. Focusing on the tibialis anterior, this muscle is the strongest dorsiflexor of the ankle, meaning it is primarily responsible for lifting the foot upwards. It also assists in inversion, which is turning the sole of the foot inward. The tibialis anterior originates from the lateral shaft and condyle of the tibia and inserts at the medial cuneiform and base of the first metatarsal, allowing it to effectively control these movements at the ankle joint. Now let's look at the tibialis posterior muscle. The tibialis posterior is responsible for plantar flexion of the foot, as well as inversion of the foot. You can see in the diagram the origin of the muscle along the posterior aspect of the tibia and fibula, and its insertion down near the tarsal bones of the foot. This muscle plays a key role in stabilizing the arch of the foot and supporting movements that require pointing the toes downward and turning the sole of the foot inward. Next, we have the extensor hallucis longus. This muscle is primarily responsible for extending the big toe and also assists in dorsiflexing the foot, which means pulling the foot upwards towards the shin. The diagram highlights the location of the extensor hallucis longus along the anterior compartment of the lower leg, showing how it runs down to the big toe. Moving on to the extensor digitorum longus, this muscle extends the toes and also helps with dorsiflexion of the foot, as well as eversion, which is turning the sole of the foot outward. The diagram here shows the extensor digitorum longus along with the fibularis tertius, both of which contribute to these movements. The tendons of the extensor digitorum longus can be seen running to the lateral foretoes. Now let's discuss the gastrocnemius muscle. The gastrocnemius is the primary muscle responsible for plantar flexion of the ankle, meaning it helps point the toes downward. It also assists in flexing the lower leg at the knee. The diagram shows the two heads of origin on the femur and the insertion into the calcaneus via the Achilles tendon. This muscle is crucial for powerful movements like jumping and running. The soleus muscle also plays a major role in plantar flexion of the ankle. Unlike the gastrocnemius, the soleus originates from the head of the fibula and the soleal line of the tibia. It inserts into the calcaneus via the Achilles tendon, just like the gastrocnemius. The soleus is especially important for maintaining posture and balance when standing and walking. Finally, the flexor hallucis longus is responsible for plantar flexing the big toe. This muscle runs along the posterior aspect of the fibula and inserts into the distal phalanx of the big toe. It is essential for movements such as pushing off the ground during walking or running, providing both strength and stability to the big toe. Now, let's focus on the Achilles tendon. This is the thick, strong tendon located at the back of the lower leg, connecting the calf muscles, specifically the gastrocnemius, soleus, and plantaris, to the calcaneus, or heel bone. The Achilles tendon is essential for walking, running, and jumping, as it transmits the force from these powerful muscles to the foot, allowing for plantar flexion, or pointing the toes downward. You can see in the diagram how the gastrocnemius has both a lateral and medial head, and how all these muscles converge into the Achilles tendon before attaching to the heel. Moving on to ankle sprains, specifically inversion sprains. An inversion sprain occurs when the ankle rolls or when the foot is inverted too much, so the lateral side of the foot is overstretched. This can stretch or tear the tough bands of tissue or ligaments that help hold the ankle bones together. Essentially, this type of injury happens when the ankle rolls towards the body, putting excessive stress on the ligaments on the outside of the ankle. In fact, more than 80% of all ankle sprains are inversion sprains. The ligament most often affected in these injuries is the anterior talofibular ligament, which is located on the outside of the ankle. This ligament is particularly vulnerable when the foot is forcefully inverted, as shown in the illustration. Ankle sprains are usually classified into one of three categories, or degrees, based on their severity. These are known as first, second, and third degree sprains. The image here shows a common scenario in sports where an athlete might experience an ankle sprain due to a sudden twist or impact. Let's start with the first degree sprain. In this case, one or more of the supporting ligaments and surrounding tissue is stretched, but not torn. This results in minor discomfort, some point tenderness, and little or no swelling. There's no abnormal movement in the joint, so stability is not significantly affected. This is the mildest form of ankle sprain. A second-degree sprain is more serious. Here, a portion of one or more ligaments is actually torn. This leads to pain, swelling, point tenderness, disability, and some loss of function. There is also slight abnormal movement in the joint, which indicates a lack of stability. This type of sprain requires more time to heal and often needs more intensive management compared to a first-degree sprain. Now, moving on to the most severe type of ankle sprain, the third-degree sprain. In this case, one or more ligaments have been completely torn, which results in significant joint instability. The symptoms can vary. There may be either extreme pain or, interestingly, very little pain if the nerve damage is extensive. Other signs include loss of function, marked tenderness, and rapid swelling. In some cases, an accompanying fracture is also possible. On the right, you can see a diagram showing the progression from a normal ligament to the different grades of sprain, with the anterior talofibular ligament and calcaneofibular ligament highlighted as commonly affected structures. This slide visually compares the different degrees of ankle sprain. In the top left, we see the normal anatomy with healthy ankle ligaments. Moving to the right, Grade 1 shows mild stretching and minimal swelling. Grade 2, in the bottom left, demonstrates partial tearing of the ligaments, with more pronounced swelling and bruising. Finally, Grade 3, in the bottom right, shows a complete tear, significant swelling and bruising, which correlates with the instability and loss of function we discussed earlier. When it comes to treating ankle sprains, the main goals are to reduce pain and swelling, support the injured area, and promote healing. The acronym PRICES stands for protection, rest, ice, compression, elevation, and support. External support, such as the brace shown in the image, helps stabilize the ankle and prevent further injury. Bracing is especially important for more severe sprains as it provides the necessary support while the ligaments heal. Shifting focus to arch sprains, let's look at the structure of the foot's arches. The foot has two main longitudinal arches, the medial and lateral longitudinal arches, and a series of transverse arches, which are divided into anterior, complete, and posterior incomplete parts. Understanding these arches is important because they play a crucial role in weight distribution and shock absorption during movement, and injuries to these arches can significantly impact mobility. Here's a visual representation of the different arches in the foot. The medial longitudinal arch runs along the inside of the foot, while the lateral longitudinal arch is on the outer side. The anterior transverse arch spans across the ball of the foot. These arches work together to provide support and flexibility, and any sprain or injury to these structures can lead to pain and altered gait. This slide provides a closer look at the longitudinal arches. On the left, you see the lateral or outer arch, and on the right, the medial or inner arch. The bones that make up these arches include the calcaneus, talus, cuboid, navicular, cuneiforms, and metatarsals. The integrity of these arches is essential for proper foot mechanics, and damage to any part of these structures can compromise the arch and lead to further complications. Here we have a detailed look at the transverse arch of the foot. This arch, along with the metatarsal arch, plays a crucial role in distributing body weight across the foot and providing stability during movement. You can see the various bones that make up the arch, including the calcaneus, cuboid, navicular, cuneiforms, and metatarsals. The integrity of these arches is essential for proper foot function, and any disruption can lead to pain and altered gait. Now, let's talk about arch sprains. Any of the four arches of the foot can suffer supportive ligament sprains. When these ligaments are stretched, they fail to hold the bones of the foot in position, which weakens the arch. As a result, the foot cannot absorb shock as well as it is designed to, leading to pain and potential changes in how a person walks or runs. Manifestations of arch sprains may include symptoms like shin splints, Achilles tendon strain, foot fatigue, muscle soreness, or even blisters. Common causes are overuse, being overweight, fatigue, training on hard surfaces, or wearing non-supportive shoes. First aid for arch sprains involves rest, compression, and elevation. Most arch sprains occur in the metatarsal or inner longitudinal arch, so it's important to address these areas specifically when treating or preventing injury. Moving on to great toe sprains, also known as turf toe. The great toe is vital for balance, movement, and speed. A sprain of the ligaments supporting the great toe can significantly limit an athlete's performance. Turf toe specifically refers to a sprain of the first metatarsal phalangeal joint, which is the joint at the base of the big toe. This image further illustrates turf toe injuries, showing the location of the big toe joint and how the injury typically occurs. The joint capsule and supporting ligaments can be damaged, leading to pain, swelling, and reduced function in the big toe, which is especially problematic for athletes who rely on explosive movements. Treatment for great toe sprain, or turf toe, follows the Price's protocol: protection, rest, ice, compression, elevation, and support. Strapping or taping the toe is also commonly used to limit movement and provide additional support during the healing process. Proper management is essential to ensure a full recovery and prevent long-term issues with balance and mobility. Shin splints is a term that's often used too broadly to describe any pain or injury in the front part of the lower leg. It's important to recognize that not every case of lower leg pain in athletes is actually shin splints, and making that assumption can lead to misdiagnosis. There are other, more serious injuries that can mimic the symptoms of shin splints, such as stress fractures and anterior compartment syndrome, so it's crucial to differentiate between them. Shin splints are generally thought to be caused by inflammation of the interosseous membrane, or strain to the tibialis anterior and posterior muscles, or other chronic lower leg conditions. Some common causes include muscle weakness or imbalance, poor conditioning, inadequate warm-up, poor flexibility or lack of stretching, running on hard surfaces, or improper running shoes. Even poor support for anatomical structures can contribute. All of these factors can increase the risk of developing shin splints, so prevention really starts with addressing these underlying issues. When it comes to treatment, managing shin splints should include cryotherapy to reduce inflammation, lower leg stretches to improve flexibility, and the use of orthotics if necessary to correct any biomechanical issues. In some cases, medical referral may be needed for further evaluation. Taping techniques can also provide support and help with pain management during recovery. Now, moving on to anterior compartment syndrome, this is a much more serious condition that requires immediate attention from a physician. The lower leg actually has 4 compartments, and the anterior compartment is tightly packed with muscles that help dorsiflex the foot. Because this compartment is surrounded by rigid structures, any swelling or increased pressure can quickly become dangerous. Anterior compartment syndrome can sometimes be mistaken for shin splints, but it's actually a different and more urgent problem, often presenting as muscle cramps or spasms. If anterior compartment syndrome is not treated promptly, it can lead to permanent muscle tissue damage and even disability. Direct trauma or excessive exercise can cause bleeding and swelling inside the compartment, which increases pressure on nerves and blood vessels. Without proper blood flow, muscle cells can die. Signs to watch for include ongoing pain even after rest, firmness of the muscle, numbness in the foot, pain with passive motion of the ankle, and visible swelling. These are red flags that require immediate medical intervention. Treatment for anterior compartment syndrome starts with addressing the underlying causes, such as replacing worn-out running shoes or changing the surfaces you run on. It's also important to rest from the activities that triggered the syndrome and to apply ice to the lower leg both before and after exercise. Stretching and strengthening the muscles in the front of the leg, as well as keeping the leg muscles as limber as possible, can help prevent recurrence. Gradual return to running is recommended, and orthotics can be very helpful in managing chronic cases. Now let's talk about plantar fasciitis. The plantar fascia is a wide, non-elastic ligamentous tissue that extends from the anterior portion of the calcaneus to the heads of the metatarsals, supplying support for the longitudinal arch of the foot. This tissue can become strained from overuse, unsupportive footwear, tight calf muscles, or running on hard surfaces, which are often the cause of plantar fasciitis and its chronic irritation. Cross-country and track athletes are prone to overuse injuries in which the plantar fascia is continually strained from running and jumping. Basketball and volleyball athletes are also susceptible to plantar fasciitis from repeated jumping and landing. An athlete with plantar fasciitis will typically experience pain and tenderness on the bottom of the foot near the heel. For treatment, the first step is to decrease training or activities that involve impact to the heel. Limiting the amount of time spent walking barefoot or in sandals can also help. A change in running shoes or the use of heel cushions, arch supports, or custom orthotics may be beneficial. Physical therapy is almost always recommended, where treatments like massage directly on the plantar fascia and stretching the calf muscles and plantar fascia are commonly performed. Moving on to Achilles tendon strains, these are often caused by overuse, muscle imbalance, inflexibility, or a sudden movement in activity. Depending on the force and condition of the tendon, the injuries can range from mild strains to complete ruptures. Achilles tendon strains must be treated conservatively due to the disability the injury produces and the tendency for the strain to develop into a complete tear. Next, we have Morton's neuroma, which is a painful condition that affects the ball of your foot, most commonly the area between your third and fourth toes. Morton's neuroma may feel as if you are standing on a pebble in your shoe or on a fold in your sock. It involves a thickening of the tissue around one of the nerves leading to your toes, causing a sharp, burning pain in the ball of your foot. Your toes may also sting. Treatment for Morton's neuroma includes RICE, rest, ice, compression, and elevation. Padding or cushioning to the ball of the foot may relieve symptoms, and off-weighting pads may be effective. Orthotic arch supports may better align the foot and take the pressure off the area. Anti-inflammatory medications can also help manage pain and inflammation. Now let's talk about rehabilitation for these foot and ankle injuries. The first step is to focus on range of motion exercises. These include dorsiflexion, plantar flexion, inversion, eversion, flexion, and extension. The goal here is to gently restore movement in all directions, and a simple exercise like using a towel to scrunch with your toes, as shown in the image, can help activate and stretch the small muscles in the foot. These exercises are important early on to prevent stiffness and maintain mobility as healing progresses. As we move forward in rehabilitation, we introduce resistive exercises to build strength in the muscles supporting the foot and ankle. Using resistance bands, like in the image, helps target specific muscle groups and improve stability. We also start incorporating sport-specific activities to prepare the athlete for their particular demands. Cardiovascular and fitness activities, such as walking, squatting, and stair climbing, are gradually added to maintain overall fitness and ensure the athlete is ready for a safe return to activity. Finally, before returning to competition, there are a few key guidelines to follow. The athlete should have full range of motion in the affected area. Their strength, power, and endurance should be back to levels that are appropriate for their size and sport. Most importantly, there should be no pain during running, jumping, or agility movements. Only when these criteria are met is it safe for the athlete to return to their sport, minimizing the risk of re-injury and ensuring optimal performance.